Welcome everyone. I believe we are live and we're just getting ready to start our webinar. We have a lot of people registered, in excess of 800 people, I believe, which is fantastic. So we will wait until 12:30 just to give everyone a chance to log on, and we will start fairly promptly then. So hi everyone, you're very welcome. We are going to get started shortly, but I do see there's a lot of people still joining. So we will give them until the actual 12:30 to start. So just give us another few minutes, please. Thank you, everyone. Another minute or two to go, everyone. I do see we have several hundred people on already, which is fantastic. And I do know there are more to join, so we will wait for them and we'll get started in the next 2 minutes. So everybody, it's just 12:30. We do have several hundred people on, but there are still people joining. So just so that they don't have to come in halfway through the housekeeping and the introduction, we'll wait one more minute and then we will get started. We have a lot to get through. Welcome everyone. I can see now we have over 400 people online and more joining. Great to see so many people joining so promptly. I'll introduce myself to start with. I'm Mary Smithick, Communications Manager, and you are all very welcome to today's webinar, which is organised and hosted by the HSE Southwest Health Region Implementation Steering Group. And the purpose of today's webinar is to give you some updates both to staff and to stakeholders on the implementation and the rollout of HSE Southwest. My role really is just to start with a little bit of housekeeping and to introduce your speakers to you. I think at the outset it's very important to point out that today is not a standalone event. It will be part of a series and it is part of a process of engagement. There will absolutely be other webinars. There will be other forms of engagement as well. I know the steering group and indeed all of the regional executive management team are very keen that we have some proper two-way engagement and conversations. So there will be face-to-face engagement, there will be town halls, there will be a staff survey going out quite shortly, so that you can share your thoughts and let everybody know how you'd like to be communicated with. I'd like to start by thanking the steering group for organising today's event, and particularly to thank everybody who's involved in the background, from the portfolio management office, from the digital team, and a whole host of people who are working in the background to keep today's event running smoothly. There's a huge amount of work that I don't really understand, so I'm very glad that they are undertaking that task for us. So thank you to them. We are very shortly going to hear from our Regional Executive Officer and from our 3 Integrated Healthcare Area Managers. But first, before we start, a tiny bit of housekeeping. And the first thing to note is today's event will be recorded and it will be shared on the HSE Southwest YouTube account. And the slides from today will be circulated as well. So don't worry if you feel that you haven't gotten all of the detail. They will be circulated and they will be made available to you. The recording is important because you just need to know that this will be on a public platform afterwards. With more than 500, close to 600 people online and more to come, we have had to, just for the smooth running of the event, everyone's microphones are muted and your cameras are off. So you'll be glad to know that you won't necessarily be featured in the recording unless you are a presenter. So that is the main piece of housekeeping. We will maybe move there now to look at our agenda, which is on the next slide. And you can see that we're about to have an opening address from REO Dr. Andy Phillips, and then updates from our 3 HSE Southwest Integrated Healthcare Area Managers. We will then move to audience questions and answers, and we really do want to get to those as soon as we can, and we want to take as many questions as we can. But you can probably already guess, with more than 600 people involved, it won't be possible to get to every single question. So what we will do, and what the Portfolio Management Office are kindly doing, is they will be capturing all of the questions. They will be filtering them to myself and I will put them to our panel once we get through our presentations. They will also be putting all of those into an FAQ document. We'll be looking at the themes and we'll be making sure that those are addressed and that you do have a way of getting answers to your questions afterwards. So there will be follow-up after this meeting. You will get that FAQ document, you will get the slides, and as I said, this is an ongoing process of engagement. And just to remember as well, you do have the option of sending your questions to the PMO office on pfmo.sswhg@hse.ie. Some people have done that in advance of the meeting, which is fantastic, and that option will remain open to you. So look, as I said, this is just one part of the engagement, an important part, but one part of it. So let's get started and let's hand over to Dr. Andy Phillips to open up today's event.
Well, thank you very much, Mary, and thank you to everybody who's joined us online. I must say that I've got a tremendous sense of excitement about what we're doing. We're really putting into effect Launch Care, and I know it's been a long time coming. Maybe you can have the next slide, please. So the real thing for people to know is that on the 2nd of March, the CHO and the hospital group will cease operation, and the 3 integrated healthcare areas will take up the delivery of services, and I'm tremendously excited about what that's going to involve. That's really going to involve a really determined approach to have care integrated for people across Cork and Kerry, and that's so important that we organise services around the needs of people, and that there's no wrong way for people to access our services, and we won't be turning people away because they don't have a particular characteristics so that they're not part of our particular service. Can we have the next slide, please? So we're part of a much broader programme across the state, and you can see the regions there. And I'm determined that there will be permeable boundaries between each of the regions, and of course that within our IHAs, they will function seamlessly across the region. So that's a really important design feature. And the next slide, please. And I really wanted just to use this next slide to illustrate how we expect things to work. So at the moment, we have a large number of teams, and they are organised into care groups, or they're organised into individual hospitals or individual GP practices. And they're really organised around how we wanted to set up the healthcare system for a previous way of dealing with disease and illness. We're really now setting this up around a wellness approach, and you can see there the centre of our system will be people's homes. And we're working not only on illness, but prevention of illness and making sure that we have all those social determinants in place, so housing, education, employment, really work in that 70 to 80% of things which keep people healthy and well in their communities. And then, of course, most care is either self-care or it's community care provided by peers or provided by communities and primary care. So you can see it's deliberately orientated there. So we don't have any boundaries around any of these types of teams, and we have the hospitals, which are very important for delivery. We have the hospitals, as you can see there on the outside of the diagram. What it will mean is that we have essentially a single hospital on a number of sites. And so part of the regionalisation is to make sure that we have, if you take a department of anaesthetics, that department works across the region. It's not specific to a hospital. So what you'll hear as we start to describe the IHA is there will be a population focus. Of course, there'll be a population focus for the IHA in Kerry and for North and East Cork and for South and West Cork. There will be a population focus, absolutely, but there then will also be coordination across the region. That's a very important design feature. Maybe we can come on to the next slide, which really talks about some of the key design features of how we're going to run this system. And you can see at the very centre is the people, the patients, the service users, who are the most important people we're there to serve. So the integrated healthcare areas will serve those people, and the rest of the regional EMT will serve the IHAs to deliver the best services that we possibly can. And you can see the operating model is built on the community health networks as they currently exist as the building blocks, and then all of the other features of the health system are built around those. And we can send you a lot of interesting slides, I'm sure, that describe those in significant detail. If you come on to the next slide, you can see that what I'm very keen to do is make sure that we establish the culture of our organisation. And by culture, what we really mean is the way that we do things. And we've set so far with the senior leaders in the organisation, we've set a purpose of a health service that our community is proud of. Of course, we have a lot of pride in our service. We have a lot of pride in our commitment, and many people on a health service work extremely hard over 7 days. We work very hard, and we need to move towards a health service that our community is proud of in terms of the access they have and the outcome. So you'll see that we've built these commitments on our HSE values of care, compassion, trust and learning. And we have commitments that we are going to make to patients and colleagues. And these commitments were co-designed by our senior leaders. And what we're going to do is we're going to involve a larger number of people soon, maybe refining those commitments and then rolling those out across the organisation. So in terms of the care commitment to patients, we want to value the time of those we're privileged to serve. And we know that access is an issue. We know it can take people a long time to access services. And when they get into those services, they're very good. But access is really important. And we know people spend too long in our hospitals and we don't achieve a good movement through the system. We know people spend too long in our emergency departments waiting to be admitted into hospital. And particularly for older people, they have a limited amount of time left of their lives. We need to make sure that those lives aren't spent in places that aren't of value to them. And then in terms of our commitment to colleagues, in terms of care, we're saying that these values, these commitments should be lived every day. So the basis of these commitments will be used for setting everybody's work programme and how we evaluate ourselves. We'll be holding ourselves accountable for those commitments as a regional team, and we'll be holding our staff accountable for those commitments. And so all of the work we're doing on people's key performance through the year will be based on these commitments. So these are very important, the bedrock of what we're going to be doing. In terms of compassion to patients, we will be putting ourselves in the shoes of those we are privileged to serve. And I know many people on this call will have used our health services and found it a very interesting experience from the other side. And so routinely we want to understand how our patients and service users experience our services and orientate them around a much better patient service and a better outcome. In terms of compassion for colleagues, we're saying we need to support each other to be the best that we can be. And that means making sure that people have all the tools to do their best job, the IT, the building infrastructure, the number of colleagues. We really want to make sure that people are supported to give the best that they can. And then in terms of trust, we need to understand that we must involve people, the people we're privileged to serve as equal partners in care and not a number. We need to make sure that we have a great care for people. And that's why all of us came into this industry, isn't it? Because we had a need and want to care for people. In terms of trust and colleagues, we're really setting that as we're one system, one team, one budget. So no more, no more that saying that this is not my service, this is not my budget, this is not my problem. It's one system, one team, one budget. And we'll be emphasising that really continuously through what we do. And then in terms of patients and learning, of course, nobody wants to harm patients. Nobody sets out to harm patients, but intentionally we want to continually reduce the amount of harm that's suffered by patients and to improve our services 7 days a week. We know that people become ill 7 days a week. We know our services aren't necessarily run effectively over 7 days a week, but we're committed to making sure that our services run 7 days a week and people are rostered 7 days a week. And then in terms of learning for colleagues, we do think that there's a need to improve our governance, and we're going to say we're going to govern our service with transparency, accountability, participation, integrity and capability. And one of the reasons why I've appointed a head of corporate governance is that we need to improve this governance. So maybe we can move on to the next slide, if that's okay. So this describes our integrated health region, and you'll see the lines drawn on the map there. Those are very not hard lines. Those are indicators of the populations that we'll be serving. We will be getting to understand the strengths and needs of the population much better, and then we'll be designing interventions along with the Department of Public Health and the Regional Director of Planning and Performance to really target some interventions on improving the health of specific populations. Look, I always talk about 6 things that we want to do, 6 things we're trying to balance, and those are service quality. So that means safe, timely, effective, person-centred and productive services. So we need to make sure that that quality is there. We also need to make sure that we deliver value for money using every year to the best of our ability to get outcomes. We need to work on that population health, not just provide a service. We need to make sure that staff receive the best experience of their service that we possibly can, and we'll be working very hard on that. We have some workshops on that coming up. And then, of course, we do need equity. We know we have particular issues in inequitable services, so rurality, our traveller population, maybe some of our older population. We need to improve the equity of our services. And finally, we need to deliver a service which is sustainable and doesn't add to the carbon burden of our system. Others will talk about some of the other features. Mary, I think. Would you like to move on to the next slide? Thank you very much. So this just talks about the regional executive management team, and we have many of those colleagues on the call. If I just run through it from left to right, at the moment we are in the process of working out the regional disability lead. We're just in final negotiations around the regional direction of planning and performance. I'm very pleased that Dr. Peter Kearney is on the call as the regional clinical director, and Peter will be organising his team of clinical directors and deputy regional clinical directors and talking to his medical and surgical colleagues. I'm also very pleased that Bridie is on the call as Regional Director of Nursing and Midwifery, and we're having discussions about Bridie's team and how that will work across the region. And then the Regional Director of Population and Public Health, Dr. Sheahan. Very important we have a population health focus in our work, and it's not an illness model. And then each of the IHA managers are going to introduce themselves to you, I think, a little later. Joe Callahan, very well known to many of you as Regional Director of Finance. Joe's been in the system an awfully long time and has some excellent colleagues working with him. Regional Director of People, very pleased that Deb Harrington has agreed to become our Regional Director of People, and Deb has an excellent team that I'm sure she'll introduce. We haven't appointed a Regional Director of Technology and Transformation yet. That will be advertised again in a couple of weeks. Jonathan Hoare has kindly agreed to become our Regional Director of Comms and Public Affairs. Jonathan will join us on the 3rd of March. And then on the call, I think we have Dan Clifford, who's the Regional Estates Lead. Daniel's brought a wealth of experience and has already made a tremendous difference to our estates function. And then the Regional Ambulance Lead, Rob Moriarty, is on the call as well. And both of those colleagues are a really valuable addition to our team. We could maybe move on to the next slide. So thank you all. Thank you for coming on the call. I'm delighted to introduce Priscilla as the IHA Manager for Cork South and West. Priscilla.
Good afternoon, all. As Andy has indicated, I'm Priscilla Lynch and I am the IHA Manager for Cork South and West. I suppose I would just like to start by saying thank you all sincerely for taking the time to join us here today. As Mary indicated at the beginning, this is the first of a series of engagements that we intend doing both at a regional level but also at an IHA level, including some town hall events. Over the coming weeks, I'm going to continue to come out and meet with all of you as stakeholders across all the settings. I'm looking forward to having the opportunity to familiarise myself with the entire IHA, but also to see the great work and practice, to meet with the teams, to get greater insight in terms of the challenges that you have, and in order for me to be able to support you to deliver integrated care. Grace, I might ask you to go to the next slide, please. So HSE Southwest has a population of approximately 300,000 and it spans the geographical area of Passage West to the Beara Peninsula. Services in HSE South and West include Bantry General Hospital, South Infirmary of Victoria Hospital, St Finbarr's Campus, Cork University Hospital, Cork University Maternity Hospital, Marymount, the Cork Dental School, Aisling. There's 2 approved mental health facilities, 23 primary care centres, 21 mental health facilities, 29 disability services, 10 community hospitals, 5 community disability network teams, 2 integrated hubs and 5 community healthcare networks. And in addition to that, a plethora of other services. As IHA managers, we have a defined geographical area and remit. However, as Andy has indicated, in practice, we operate as a single region to ensure integration at all levels. And to support this, we're going to hold a regional portfolio brief, and I hold the brief for primary care, children's services, and social inclusion services. Grace, I might ask you to go to the next slide, please. So again, as Andy outlined at the beginning, we are on a journey of delivering sláinte care. It has been designed, I suppose, first and foremost around the needs of the person. Integrated care has a dual aim in terms of improving both system efficiency, but also in terms of that service user experience and outcomes. This commenced with the implementation of the integrated community healthcare and the delivery of the community healthcare networks. Now, those of you that are on the call here today will be very familiar with this term. Community health networks are the basic unit, I suppose, of integrated care. Services are mapped on a geographical basis into approximate population size of 50,000, and each CHN or community healthcare network has a number of primary care teams that is operationally managed by the community healthcare network manager. The network manager then works very closely with the various different heads of discipline who provide the clinical governance, such as speech and language therapy, occupational therapy, physiotherapy, social work. But in addition to that, there are also a number of other services that work alongside, such as public health nursing, dental, area medical officers. They also may come under the operational governance of the CHNs. A critical aspect in terms of the operation and the success, I suppose, of the CHNs is the input from our GP colleagues who work closely with the teams with respect to both patient and clinical care. You'll see here on this infograph that CHN Plus is referenced. And I suppose just to state that that is a design working title. Really what it refers to is the increased range of services in the geography of the existing CHNs that will be managed together in the new structure as and from the 3rd of March under the health and social care managers for each respective IHA. Increasing the range of services that will operate in this guise. And again, it's very much teeing in terms of what Andy indicated with the original infograph around Sláinte Care. It is us operating as one healthcare family for all services with the patient at the centre of that. So in addition to your CHNs, as I've just described, you would have CAMs, mental health teams, home support, health and wellbeing, and it is inclusive of the HSE and section 38 and 39. So the essence of today's webinar is actually to spend the majority of the time taking questions from your good self. So we're not going to do that by PowerPoint. So I'm going to end here and I'm going to hand over to my colleague, Julie. And we will stay online, obviously, and answer any of the questions going forward. Thank you.
Thanks very much, Priscilla. Grace, you might move on. So good afternoon, everyone. My name is Julie O'Neill, and I am the Integrated Healthcare Area Manager for Kerry, which has, as you all know, a population of nearly 160,000 people and growing. So Kerry has 3 community healthcare networks. North Kerry, which is known as Network 1, consisting of Listowel and Castle Island. West Kerry, inclusive of Tralee and Dingle, and indeed South Kerry, which is Evora, Sneem, Killorglin, Kenmare and Killarney. And I will be integrating all of the services in Kerry, and we will be working as one integrated healthcare area management team to deliver on our commitments to ensure accountability and a patient-centred healthcare system. So also, as you will all be aware, Kerry encompasses University Hospital Kerry and indeed our community hospitals and all of our community services, including mental health services, primary care, disability, older persons, health promotion and social inclusion. Next slide, please, Grace. So as Priscilla outlined earlier, in terms of ensuring our integration of our management team, the integrated healthcare area managers will carry lead responsibility for agreed portfolios at a regional level, and they will be supported in these roles through the health and social care managers and the associated teams across the IHAs. So the new model aims to achieve both horizontal and vertical integration. Horizontal meaning multidisciplinary team working across all health and social care services and all other healthcare providers, as well as interagency collaboration to achieve really good health outcomes. And then secondly, vertical integration, focusing on the joining up and the combining of primary care services, community services and hospital services. I will take the lead regional portfolio for disability and mental health. Sonya, Cotter, the IHA manager for Cork North and East, will have the regional portfolio for older persons and acutes. And Priscilla has already outlined she would take primary care, children's and social inclusion. So the model features a core primary principle of ensuring a flat management structure to ensure that we can fulfill our role of managing the operational service delivery within the IHA geography across the acute and the community care services. And also to ensure that we reinforce and we ensure integrated ways of working across all services within and across the IHAs and through the networks of care, irrespective of structures, and that we all remain operationally driven. Next slide, please, Grace. So this slide then represents the IHA management team, and this will consist of the health and social care managers at head of service and general manager level. So there will be health and social care managers with accountability for the hospital and discrete community services in each of the IHAs as appropriate. There will be health and social care managers with accountability for the community network services, and these, I suppose, feature the very high volume services that sit in each community network or across a group of CHNs. So that will include the current CHN teams, the CDNTs, public health, nursing, mental health teams, older persons, short-term care, liaison, community support teams, etc. We will also have health and social care managers for low volume specialist services, and these include primary care services such as audiology, the community intervention teams, palliative care teams, the mental health specialist teams, the inpatient teams, some of the disability services, social inclusion hubs, and other services that exist in each of the IHA, such as the labs, civil registration, and safeguarding. And these are just examples. The list isn't exhaustive, and we have, quite varied services across each of the IHAs. So the IHA management team will also have clinical representation to include the executive clinical directors, the CDs, GPs, nursing and health and social care professional leads. And Andy referenced earlier, we're currently working that out with our colleagues across our regional and executive management team. We hope to be able to give you more details around that soon. There will be a dedicated IHA QPS role currently under discussion nationally. And then, as Andy referenced also, we have dedicated partnering and supporting from our enablers, which is inclusive of our finance teams, our HR teams, our people teams, digital, communications, estates, and of course, the National Ambulance Service. Next slide, please. Sorry, next slide, please, Grace. And I think I'm handing over to Sonya at this stage. Thank you.
Thank you, Julie. Good afternoon, all. My name is Sonya Cotter, and I'm actually delighted to introduce myself as your Integrated Healthcare Area Manager for Cork North and East. So Cork North, next slide. Thank you. Cork North and East. So this area serves a population of just over 285,000 people, which includes 6 community health networks. It really spans from the north side of the city, right up as far as Charleville, and over to the east side to Youghal. And we have 6 CHNs within this region. We have Model 3 Hospital, which is Mercy University Hospital, Model 2, which is Mallow Hospital, and we also have St Mary Health Campus and 7 community hospitals, along with all other community services. So I'm really looking forward to meeting you all, well, hopefully all of you, and to get to know you, and to really kind of look at how we can improve services in an integrated manner across Cork North and East. For the last 8 years, I have been having a national role, and I really am happy to be back working locally with you all. So as outlined from my colleagues, really, we know that our priority is Sláintecare. And the introduction of the regions and the IHA areas is a great step, a great stepping stone to actually for Sláintecare. And we know the premise behind Sláintecare is right care, right patient, right time. We really need to focus on and start, looking at equal access to health services for all our citizens. And the one area that we will be looking at towards this year, one of the areas that I'll be looking towards this year, is really about access and equity for all. Priorities for the HSE Southwest region is improving safe, timely access to care. We will be looking towards the Urgent Emergency Care Operation Plan 2024, and that includes Q1 2025, and the Waiting List Action Plan. We'll be looking at building on the great work that has been done already by you all in 2023 and 2024. Government has set ambitious targets within the NSP for UEC and scheduled care, and we will have to look at achieving those targets. We also now have an additional focus on waiting times for other services we provide for access, and that is within primary and community care in all settings. And working towards this together, I really do think that we start building integration and, you know, equal access for all our patients and service users. Thank you.
A huge thank you to our REO and our 3 IHA managers, particularly because without any prompting from me, they have managed to keep us on schedule, which I'm sure we're all very grateful for, because we do want to move to questions and answers now. So I will remind you that you can put your questions into the question box. If you look at the very top of your screen, there is a section for you to put in Q&As, so type them in there. They won't be seen by the entire, if you're worried about everyone seeing your question, no, we'll just put them individually to the panel and members. We have had some questions in advance as well. I do see questions coming in now on the chat box, but I might move first of all to one that came in via email to the PMO office in advance, and that was from someone who says they currently work in primary care, and what they really want to know is what do these changes mean for them in terms of their reporting relationships and what will be different for them from the 3rd of March. So Priscilla, as you're our primary care lead for the region, I might go to you on that first, and if anyone else wants to come in, please let me know.
Okay, thanks very much, Mary. Certainly, I think Julie has outlined that already in terms of the slide for the implementation. So we will move to implementation and it will commence from the 3rd of March. And as Julie indicated, it'll take approximately 6 months. As and from the 3rd of March, the IHAs will be established. Both Cork Kerry Community Healthcare and South West Hospital Group will formally be stood down. In the immediate future, the majority of staff will not be affected. Services that are in operation today will need to continue to be delivered safely as and from the 3rd of March. I want to take this opportunity really, I suppose, to reassure people, particularly individuals that use our services, that there will be no disruption to the services that will be available as and from the 3rd of March. Obviously, as Julie has indicated in terms of the IHA structure, roles of senior managers such as heads of service and general managers will be changing in the context of the geographical model. However, as also outlined by Julie earlier on, there is continuous consultation and engagement, and that will remain in place until a finalised structure is completed, and naturally that the HR processes that are there to support that have been implemented. I do appreciate that change is difficult and that it unearths people. However, this is a really exciting time. We have huge opportunities here whereby we have ownership for our health services here locally in Cork and Kerry, and by working with all of you and your teams and the patients that use our services, that'll inform our planning in terms of how we deliver our services moving forward and meet some of those targets that Sonya outlined earlier on, and that we can be immensely proud of our services going forward. But just really to reassure again, going back to the question, Mary, at heart, is that the majority of staff in the immediate future will not be affected and services will need to continue safely.
Okay, thank you for that. And I will remind people you can still continue to put your questions into the chat box. I see quite a lot of questions coming in now, which is great. And we do have another 25 minutes or so to work our way through them. And just a reminder as well that there will be a process afterwards where there will be an FAQ document issued and there will be further engagement as well. One kind of detailed question, and it is very much related to the regional implementation steering group, but I think a good question to put to this forum. And first of all, this person wants to know what subgroups of the HSE Southwest Regional Implementation Steering Group have been set up. They want to know the chairperson and the membership of the steering group. And we may not be able to give the full list today, but it will be circulated afterwards. And then, yes, related to that, who is sitting on the steering group? And then finally, and Julie, you may have covered some of this in your contribution, they're asking, is there an outcome from the 2 national workshops referenced in the communication sent to staff by the broadcast email on the 4th of February? And those are the workshops in respect to the proposed structure and governance work.
Thanks, Mary. I'll take those questions if that's okay. So indeed, there is a steering group that we have established as we got closer to understanding what was the agreed national integrated healthcare area design. And just to reiterate, Mary, sorry, apologies, I didn't say it on my slides, but this has been approved. So the slides that we have here, they have been, in terms of the IHA structure, they have been approved by the Health Regions Governance Group, just this week in February 2025. So people may not be aware, but certainly senior management across Cork Area Community Healthcare and the South West Hospital Group will be aware that we have set up and established our regional steering group, and that is co-chaired by Sonya, myself and Priscilla. And we have very clear terms of reference for that. And I suppose it's simply put, and we will circulate those to colleagues after the call, but simply put, it is to implement now the next phase in terms of the rollout of the integrated healthcare area regions. And we have members right across the board, from patient representation, staff representative bodies, disciplines, care groups, community services on that steering group. There are 3 subgroups and 3 work streams to that steering group. The one that I chair with Sonya is around the design of the service delivery model. So we're taking the slide that we presented there in terms of the IHA structure. We are taking that and looking at that and seeing, how does this actually translate now to the structures in Kerry, in Cork South and in Cork North. And we have circulated and we've looked for feedback on what that, a version of that. We had 2 proposals, and as I outlined earlier, the preference nationally is for the flat structure and the approved model is the flat structure. So that has gone out now for further consultation. We're gathering all of that information, and simply put, we're looking at, for example, Kerry is a good example. How many health and social care managers at what level do we need for example, for acute services? What falls in under that CHN plus service, and what falls in, how many health and social care managers do we need for the specialist services? So that has been done for each of the 3 integrated healthcare area regions. That's the first work stream. The second work stream, which has developed this webinar today, is the communications work stream. And again, just to reiterate what colleagues have said, we will need these groups to assist in terms of the further rollout of the communications of the model and how it impacts, all staff and all services as we move into that, active implementation stage now from the 3rd of March into for the next 6 months. And the third work stream is the networks of care work stream. So we have had and that is chaired by Dr. Peter Kearney and Bridie and myself, and Sarah Sheahan, who is the health and social care professional lead, is also very involved in that. And we're just finalising the terms of reference for that work stream, Mary, because I suppose we're working in a situation where we have now a draft blueprint set down nationally for the networks of care. So we're working through that and how it actually fits to our own regional structures there. So there are 3 subgroups. Now, when we met last week, and as Priscilla said, we will circulate the members of those groups. But when we met last week, what was very much coming to the front, and we know this, we need to establish a HR work stream now as well, just to ensure, I suppose, that we are reassigning colleagues to particular roles, as per agreed by the National Joint Council, which is the staff representative body. And we will be putting together, I suppose, the final numbers of posts in each of the IHA management teams. So we have to assign colleagues into those roles. So that HR group will support us with that. So we'll have to finalise the terms of reference on that. So 3 commenced at different stages. They're the 3. The overall steering group has obviously commenced. 3 work streams at different stages of work. And 1 about to start as well. I suppose the other thing really that we're focused on in the steering group is really looking at that change impact, you know, and how and risk assessing what this change means, you know, for the services, and ensuring that we have a very clear transitional planning and a robust due diligence in terms of the handover activities that, you know, we need to put in place now for the coming weeks. And we have due diligence and handover meetings, etc., established for next week in, you know, but I suppose we're not under any illusion that, you know, we just switch it on the 3rd of March. And that's where we're absolutely going active and live in terms of our integrated model. But there will be further implementation over the 6 months. Mary, thank you.
And Julie, thank you. I do see a lot of questions coming into the chat, which very much relate to people wanting to know where they will sit within the structures, what the reporting relationships will be. And I see the questions echoed for different care groups, people asking what will the structure of governance look like for safeguarding, what will be the approach for mental health, what will be the approach for suicide prevention, what will be the relationship with disability services. Would it be fair to say that the process you've just outlined will be looking at all of that? And is there anything that either the REO or the 3 IHA managers would like to add to the people asking those particular questions?
And Mary, absolutely. You know, as I said, when we went out for that wider consultation around the specific services at a geographical level, and some colleagues will recall we had some workshops in Westfield and Ballincollig as well just before Christmas, and all of those questions are coming up. So we are endeavouring to design exactly as you say, in terms of what that looks like for mental health colleagues, safeguarding, etc. But they will map into that the approved governance structure that we presented there this afternoon. So all of the services and the staff and disciplines that you've mentioned, they actually do fall in under that grey box, that pink box, that purple box. And I know colleagues need time to kind of digest and try and understand that, but there will be plenty of time for, you know, exactly what does that look like where I work. What will my reporting line of governance be? We will be able to answer those questions, and we're working to ensuring clarity around that. So
fantastic.
I suppose we have some way to go, but we're nearly there, Mary. Thank you.
Okay. That's great. Conscious now that we have a lot of questions to get to, so we'll try and be as thorough as we can, but try and keep the answers short, and we'll ask people to remember as well that we will be coming back to them with the FAQ document as well. I do see very specific questions about the disability sector and what the relationship is going to be with the IHA managers and so on, and asking particularly, will this mean more access to mainstream services for individuals? And more generally then broadening out, we have questions in terms of where does the Section 39 fit in this process? So is that something that we can address briefly, please?
Yes, I keep my answers quicker. So yeah, the disability services as they stand will continue to be delivered by the Section 38 and Section 39 organisations. There's no change, as I say, from the 3rd of March, but we will be in discussions in terms of that, you know, how we integrate disability services to ensure further integration of disability services into mainstream. We are and to ensure that people with disability have equal access to the health services as everyone else does. Mary, thank you.
Great, thank you. I see a specific question here that we may not have an answer for now, but we can obviously keep on the agenda, and it's under which health and social care manager do the chronic disease hubs and the older person hubs sit?
Do you want me to take that, Mary?
Yes, please. Thank you, Priscilla.
Yep. So they are co-terminus as it stands at the moment with the CHN. So for a lot of people on the call, they will understand that the chronic disease or integrated hubs, which is both chronic disease and ICPOP, are co-terminus with approximately 3 CHNs. So the intention is that the health and social care manager that would have a remit for those geographical areas would also have a remit for the services that are delivered through the hubs. services equally. But I think, as Julie's indicated, as part of the ongoing work around finalising exactly where every service is mapped in the region per each IHA, a lot more clarity will be provided in relation to who's remittent and what they'll be covering.
Absolutely. Thank you, Priscilla. I see one question here that I think we can give a nice, easy answer to. Someone asking, will there be an infograph available displaying services sitting under each IHA? And look, we have a real commitment to ongoing communication, not just digital, and we are working on one-page printed resources as well. Some of those have gone out, and all of that will be coming from the steering group. So I think absolutely the answer to that is yes, there will be all sorts of those kind of resources already started, and there will be more coming as well. I do see a question that relates to recruitment, and this is one that came into us before the event, and the question is asking in terms of panels, what is the plan for future recruitment and what happens to existing panels? And the person really wants to know the existing panels that are in place for community and acute, are those going to be amalgamated, or will it be that those are left to be exhausted and then there will be a new campaign? And they're referencing the fact that there are currently some panels active for both community and acute services, which have been there for a little while. So that maybe is something that either the REO or the IHA managers want to come in on.
I can take that, Mary, if you want as well.
That would be great.
Yeah.
So everyone knows this is Deborah Harrington, the incoming head of HR.
So I'll be commencing a post on the 3rd of March, and one of the first things I will be looking at is the existing panels that are in place. Again, reviewing the numbers and where they are, and we'll put a document together on that and look then. And obviously anything in relation to any changes, we'll be engaging with staff. So it has to be reviewed in the first instance. So I would just say to people, there's nothing being done right now, but very soon we will look at all the existing panels and we will communicate then with staff as to what the position will be.
Perfect. That's great. I think that's clear and to the point. So thank you very much. Sorry, as I'm talking, I'm actually scrolling and looking for the questions as well at the same time. I do see that we are joined by Cathy McGrath from the Disability Federation. Cathy, we're very glad that you're here today. And she is thanking us for including the voluntary disability sector today and asking us how the Disability Federation of Ireland can facilitate and support this engagement, particularly with their members. So I'm not sure which of the executive management team would like to come in on that, but we do thank Cathy for taking part today.
I can come in if you want,
Thanks,
Mary, there.
Priscilla.
Just say thanks very much, Cathy. I think we will look at establishing a forum here locally whereby we can have engagement with all of the parties that you're referencing there, and seeing how we can work collectively together over the next number of months to ensure that we deliver services that's appropriate to individuals with disability. And I know, Cathy, you're on our regional steering group, and so certainly that's an avenue that we can cover in more or less the immediate future. We'd be delighted to do that. Great to have you on board.
Great, fantastic. Keeping an eye on the time, but I'm glad to see that we still have 10 minutes and we still do have more than 700 people with us. So thank you for bearing with us. You still have the opportunity to put your questions into the chat box, and we will get through as many of them as we can in the next few minutes, and we will stay on as long as people need to. But I do appreciate people may need to leave at 30:30. One interesting question that has come in here is, how will people who live on the borders, and that would be on the borders of CHNs, of IHAs, integrated healthcare areas, and indeed of the region itself, how will they be able to access services, and will they be able to choose which services they seek, which I think is an interesting question.
I'll take that one, Mary.
Great, thank you.
So really the entire concept is that there are no rigid boundaries, there are permeable boundaries. The IHA managers have a population accountability for that particular population, but that isn't a rigid boundary. So people will be able to choose. And in fact, people in this state have the legal rights to choose. And in fact, we will be encouraging people to choose our services. And just for colleagues who think that they'll be overwhelmed, there will be a population-based resource provision so that the money will follow the patient. And so the more patients that we have in our region, then the more resources we'll have to provide those. So we'll be welcoming those. We already have some really good networks. We have a maternity network, trauma, cancer, and those networks bring in patients from very wide population, well beyond this region. Thank you.
That's great. Thank you for that, Andy. Questions are still coming in, and again, we may not be able to answer these in detail right now, but we will raise them. And we have a person asking if clinical managers, for example, dietitians, physios, etc., will they remain separate for acute and community services, or will they be merging? Not sure who'd like to take that particular one on. Or indeed to say that it's something that that we can get back to people on.
I mean, that is an IHA manager discussion with the relevant teams, but really the concept is we don't have a specific team in that way, that we have a group of people in a population, the group of people work well together. They're not necessarily assigned to specific teams. They will have a particular function, and we do have some care groups we need to serve, but within an IHA, there will be a team of people not allocated in that way. And certainly hospital and community separation is not really where we're at in terms of integration.
Okay, thank you. Priscilla, I see you unmuted as well. Do you want to come in?
Oh no, just to say really that our health and social care managers, I mean, they add huge contributions to the care of patients. So we'll be working closely with them, both who are presently aligned to the community and the acutes. And I suppose just to re-emphasize what Andy had said, it's an integrated model going forward. So it's how we deliver the best care and how we have the most robust clinical governance in place. So we'll be working and engaging with parties in terms of how that will be delivered in the future going forward.
Fantastic. I see a question here that really relates to digital matters, and I know we may not be able to answer it on the call today, but I do think it's something that people would like raised and would like flagged, and I don't think there'll be anyone disagreeing with this question. And the question is there anything in relation to delivery of care, sharing of information between disciplines, that charts will be computerized for sharing of information, for example, between GPs and hospital settings? And I know that is something that everyone would like to see happening.
But should I take that? Because that's a key enabler of integration. And so we have to push for that. And we'll be pushing in particular for our region to be at the forefront of that work. We haven't appointed yet a regional director of technology and transformation, but we'll be moving forward with that. And we also will be seeking investment from the government on some of these really important enablers, such as the electronic patient health records. We do have a good programme that takes those things into account. I just want to make sure those things happen sooner rather than later, because they're key to integration and this work.
Perfect. Thank you. And the next question is in relation to recruitment, and someone asking, is there scope to enable more local hiring of staff, as panels can take a long time to get staff in post? So again, I see the IHA managers all smiling and agreeing. Deborah, do you want to come in briefly on that one?
Yep. So there is a recruitment operating model, which, so there are certain grades which are recruited nationally, and then it allows us to have that local, again, flexibility around, we'll say promotional grades in terms of local recruitment. And obviously we have separate, we'll say, recruitment functions at the moment across the two organisations of the hospital group and the community. So obviously we'd be looking to bring in, efficiencies there and try and make the process as smooth as possible for candidates as well. So yeah, and we'll engage with staff and keep them updated as to, any changes that are happening. I think that's really important as well in terms of the role of the people function, to keep staff, to listen to people, but also to keep staff updated as to any changes or proposals that are ongoing as well, and to hear their opinions on things as well. Actually, it's really, really important. So yeah, we'll be working on all of that.
Great, thank you. As always happens with these events, the questions are coming really thick and fast now. I know that not all our audience may be able to stay on, but I'm quite sure that our panel are quite happy to keep going through the questions for another little while. So we might do just a round of questions where we try and give a very fast answer if that's possible. And one very pertinent question that someone is asking, is there extra funding provided for the integration for resources and recruitment? Andy, you might want to take that one briefly.
Extra funding. There's no extra funding. We've been funded to make this happen, and I believe we do have the money to make this happen. There will be some key gaps that we have, and we'll be seeking support from the centre. The colleagues may know that the CEO has asked that a number of colleagues from the centre will be moved to the region, so we'll certainly be accepting those colleagues to fill in some of those gaps. But I see Jer as it's hand up.
Yeah, just to add to what Andy was saying there, look, it has to be cost neutral, and that's going to be the challenge. And if we have to create posts in one area, we're going to have to move people around. So that's just the way it is. So obviously the plan is that we make efficiencies at the same time, which give us more flexibility, but that's the position. Thanks.
Great, thank you, Ger, and that's Ger Callahan, our Regional Director of Finance. Yeah. So again, just a few other quick questions, and I think this may be a point rather than a question, because I think everyone will agree with this. Just wondering if there will be opportunities to avoid duplication, drive quality and drive efficiencies, and is that something that we see happening? I see everyone nodding. Anyone want to make a specific point in relation to that?
Yeah, I'll take that. We need to design our work so those things absolutely happen, and there will be a very particular drive to make those things happen. One of the 6 things that I say that I hold dear is value for money. So we'll be driving value for money.
That's great. I know that we have talked maybe earlier and in other forums about population profiling and the importance of that and how it'll drive an awful lot of our decision making. So we just have a question here for Dr. Anne Sheahan as Regional Director of Public Health, just asking to tell us a little bit about that population profiling. Has it been done and where is it?
Thank you for that. Yes, there is. There has been quite a bit of work done in the past in preparation for this around population profile. So we have a population profile for our southwest region, and then we have it down to CHN level. We're also working with, there's a national population-based planning group working, and we're working closely with them to look at probably more specific population-based planning and to look at developing more specific profiles around particular groups like older persons, disability. So there's lots of work planned into the future on that, but there are currently profiles that will help inform our health service development.
That's great. Thank you very much. I think we will keep the questions going for another few minutes if all of our panel are okay with that. For anyone who does need to leave at this stage, we'll just remind you, you'll be able to watch this webinar back on the HSE Southwest YouTube channel. There will be, as we've mentioned, an FAQ document addressing the themes raised from today's event. You can still send your questions to the email address on screen to pfmo.sswhg@hse.ie. There will be a staff survey coming from the steering group in the next 2 weeks or so. And as we've mentioned at the start, there will be more webinars, there will be more face-to-face engagement, there will be town hall meetings, there'll be engagement across the region and then at IHA level as well. So just, if you do need to leave us, please watch out for all of those and bear in mind that you will be hearing from everybody again. But just to keep going on a few more of the questions, if we can, again, just a few ones that we could answer quite quickly. Someone is asking about the HSE climate strategy and setting up regional climate teams, and how is that progressing? Andy, that's something you might want to take.
Just very quickly, again, climate and sustainability is something I want to build into everybody's work and everybody's requirements for delivery. Thank you.
Okay, that's great. I do see a question, and again, I think this might be for everyone to feed into, but it's particularly asking what is the union position on the change? And I know there's been a lot of engagement.
Should I just take that one quickly? We're working very closely with our union partners. Of course, our unions want to ensure that we are consistent with our current agreements. This came up in the Dáil yesterday, that we want to be absolutely consistent with the agreements and the partnership that we have with the unions. There is a lot of conversation with the unions about this because it means a lot of change for many people. But the intent is to move forward with unions as our partners.
Just another question where we might be able to give some reassurance to people. We have a staff member asking what happens to current waiting lists with this restructuring.
Yeah, I'll tackle that. Current waiting lists will reduce. So we're looking to have greater productivity as a result of these changes. We want the time that people spend waiting on waiting lists to reduce, and we want the total number of people waiting. So we will be doing a lot of work. And as I think Priscilla outlined, that's a key requirement of the IHA manager. So the waiting list will reduce.
Okay, great. Good to hear. We have an interesting question here, and we might bring Dr. Peter Kearney, the Regional Clinical Director, in on this, just asking about shared consultant care across acute and community settings, and just following the model and the notion of keeping the patient left, which means keeping them in the community and out of acute hospitals where possible. So Dr. Kearney, if you're there, if you'd like to talk to us about that idea of shared consultant care.
I'm struggling a little to understand exactly what the question is getting at. As we see it, we will have, I mean, consultant care shouldn't be confined to one or other of the sites. Our appointments are to the region, and so provision of care will be for patients across sites. And we have that model already in place in various hub jobs. So I would say that it's something which will be facilitated by the changes and by our new contract. Andy has a comment to add to that as well.
Yeah, so if you take your own specialty cardiology, Peter, I can imagine that you'll be working even more effectively with our primary care colleagues on managing hypertension, managing atrial fibrillation, and of course with public health team on managing healthy behaviours to reduce the incidence of heart disease that you then have to employ your skill to affect.
Yeah, and I would say that it's a model which is in place already. I mean, we have HeartWatch, we have that cooperation already in place, but it'll certainly be facilitated by breaking down the boundaries between hospital and community, which is obviously a key part of what we're doing here.
We might take 3 or 4 more questions if everyone is still okay with working through some of them. A very specific one about networks of care. Do we know them yet? How will they function in respect of frontline teams and therapies? Andy, I know you'd like to come in on that, and perhaps Dr. Kearney as well.
Yeah, and you know, Peter's going to have a view on this, but look, I don't see networks of care as a separate or special thing that's coming about as part of this restructuring. So every clinician that I know is involved in some sort of network of care, whether it's a journal group or it's an informal meeting or whether it's a professional association. There are networks of care. And if I think about the formal networks of care, we already have a trauma network. So we have a South Trauma Network. We have a very effective maternity network across the different regions. And I can see the potential for further networks. Formally, what we've decided to do is to have a network of care for older people. So we're already the starter region for age-friendly health systems, and we want to do the same thing with child-friendly health systems. So networks of care aren't really new things. We need to explain them better, but we already have them. Peter?
Absolutely, Andy. And, you know, just beyond that, we have the stroke network. We've got the primary PCI network. So there are many well-structured networks. There are multiple informal networks already in place, and I think it's very welcome that we look at formalizing some of these disciplinary networks to ensure they work better. It ensures more uniform standards. It improves accessibility. So it's something that we look forward to developing as a part of this program.
Great. We will finish up very shortly, but there are 2 questions that I am just going to band together here because I feel we might be able to provide some reassurance for staff on them. And they are, when will we know if our GM, our general manager, is changing areas? And then also we have someone asking, is it, and I presume they mean any change of roles, will that be done by reassignment or interview when roles come up and change? So we might just be able to give some reassurance on that. I think Priscilla is trying to come in. Yes, you can. Yes, please. Thank you.
Don't want to be jumping ahead of anybody else. I suppose in relation to the timelines, that's been driven by the agreed HR processes and of reassignment and recruitment, particularly for the grade mentioned in terms of head of service and GM. So that's going to be progressing a parallel process with us here locally in the region, but it will be coordinated nationally by NRS and obviously in accordance with the agreement with the representative bodies. So absolutely, once we, as Julie outlined earlier on, once we have the finalised map in terms of the structure for each of the respective IHAs, then the direct engagement will immediately commence with the said parties. So obviously some of that work will be undertaken as soon as next week, and once the individuals in question have had an engagement, then obviously there will be the broader dissemination in relation to that.
Fantastic. Deborah, I'll bring you in very briefly and then we'll just start to wrap up.
Yeah, it was just around to make sure that everybody has access to the HR principles document on reassignment and redeployment that was circulated through, I know I circulated through my own system in as I'm in at the moment in mental health. So I would just say to people on the call to contact their line manager and make sure they have a copy of that, because that was the one that was signed off at Joint Council. It's quite clear, actually. It sets out a really kind of clear process. I suppose it gives comfort, I would think, to look at it. It's very, you know, detailed, fair, and at all times we'd be adhering to public sector agreements, obviously, as well as this new HR principles document as well. So it is available, and I would encourage people to take a look at it, because I think that will give people a level of comfort as well.
Great, very important document for people to make sure that they get hold of. So Andy, I'll bring you in briefly.
Yeah, it's not around that, but Kathleen raised a really important issue about equity. And Kathleen asks what measures are going to be put in place to ensure vulnerable patients are not losing out through the various things that we do. So in everything that we do, and I describe that in the 6 things as equity, we need to make sure that there are no unforeseen consequences of some of the things that we do. So Kathleen, I can absolutely assure you that we'll work hard to make sure that those vulnerable people will be advantaged rather than disadvantaged. And that means that we need to interact with vulnerable people in a different way than the standard way that we might interact. So great question, Kathleen. Thank you.
Just before we finish up, someone is just asking, Deborah, if you could give that document title again, just to make sure that people are aware of it.
Yes, certainly. It's the HR principles document. It's on redeployment and reassignment.
Great, thank you very much.
I'm not sure if we could push it into the chat or that would help or anything like that. I could look to do that. Could drop that into the chat. Oh, it's turned off. Sorry, apologies. But it was circulated through the line management system, so everyone's line manager should have a copy of that. And if not, we'll be happy to circulate it again if anybody's looking for it.
Fantastic. Just one last, maybe very fast answer from people. We have someone wondering, is there a final date for implementation? Which is an interesting question.
Yes, we need to get this done within 6 months. So the final completion of implementation will be by the first week in September 2025.
Fantastic. That is great. I think that is a good place to leave the discussion for now. Just to finish up, I really wanted to thank our presenters for their time today. I want to thank everyone involved in the logistics, both in the PMO and in the digital team. There's a lot of work going on. Delighted to see we still have about 500 people with us who've borne with us throughout all the questions. So thank you to the audience for giving up your time, for giving up some of your lunch break, for giving us so many questions. There's a lot of follow on there now for everybody involved. This is part of the engagement. You will be hearing from the steering group again. There will be more communication coming towards us, towards you, and you will be seeing the follow up from today's event. So thank you very much and enjoy the rest of your day.
Thank you.
And thank you, Mary.